Here's a reason I like headaches. I don't actually love treating headaches more than any other kind of orthopedic problem, but I will say that headaches can come up when I'm trying to talk to people or educate patients about the difference or the occurrence of referred pain and how it differs from muscular symptoms that are actually due to muscle damage or muscle lesions or problems. The thing about headaches is that most people understand when you ask them, where do headaches come from? That they can come from multiple problems, right? Dehydration, a medicine you took, maybe even hunger, sleep deprivation. Maybe they'll even know that sometimes it comes from joints in the cervical or thoracic spine, but they're usually not jumping to the idea that it's muscular where the symptoms are. They're typically not saying, I need to strengthen these muscles in my forehead, or I need to stretch these muscles on my forehead or the muscles around my cranium, because they understand that it's not likely that a headache is due to a muscle problem. Now, some people will think it's muscular from the muscles in the neck. I don't find that to be the case, but maybe that is the problem in some people's headaches. But if I can get them to understand that headaches are often referred symptoms, or a headache is a referred symptom from another problem, or it's just a symptom of another problem, then I can start them understanding that their quad pain, which I would call anterior thigh pain, is not necessarily from the quad muscle. We don't need to stretch and or strengthen the quad muscle. We need to consider what problems can send symptoms to the anterior thigh. Now, the more I take a verbal history, the more I take baselines, the more we do testing, that funnel of possibilities of what can cause anterior thigh pain should be whittled down to a few. When I finish my specific verbal history, I like to have 2 ideas that I'm really grappling with that I will test when I test the baselines and the testing later on in part 3. But that's why we have differential diagnoses. A clinician needs to know all the things that could cause anterior thigh pain, or at least the large majority of things that can cause anterior thigh pain. And if they run out of ideas, they need to know where to refer the patient. But anterior thigh pain for me, often radiating from the hip joint, often radiating from the lumbar spine, maybe the SI joint. Of course, in the specific verbal history of the patient saying, I was playing soccer, I made a kick and I felt a snap in my anterior thigh and now it's black and blue, we are thinking muscle tear. But the average person is not tearing a muscle unless they remember an acute event where it tore. But by the same token, since those people are rare, it doesn't make any sense that so many people think they're just straining and tearing their muscles all the time. It's a little bit the same with ligaments and tendons. There should be an acute event for structures like that where you feel that the structure is actually impacted and damaged. Most people are not reporting those acute traumas. They may report an acute event, right? I bent over to tie my shoes one weekend in the morning and my back went out, but that was not trauma. That was just a normal event that caused a catastrophe, but it wasn't trauma enough to the extent that we're thinking it's actually major structural damage in most cases. So again, that headache analogy is kind of a fun way, or at least a relevant way that people understand to point out that it's not necessarily the muscles, but symptoms that are referred from joints, symptoms that are referred from discs can spread. And we have maps of those, and we can pinpoint where, when someone's talking about their quad, for example, and I'm thinking anterior thigh, we know what can refer to the anterior thigh. So I want people to consider that symptoms are referred because I see a ton of referred symptoms. For example, symptoms in the biceps area where a patient told me he thinks he strained both biceps coming from the lower cervical spine. Referred symptoms are very, very common. Maybe we can use the word radiate. In certain cases where the nerve root is truly impacted, we would call it radicular symptoms. Those are much rarer, and they're typically corroborated or accompanied by neurological symptoms in the extremity. But referred symptoms are very normal, just like referred symptoms into the head. We can have referred symptoms anywhere in the body, and I want people to understand this so they're less likely to automatically incriminate the muscle where the symptom is.